Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning. Please have a seat. How can I assist you today?
Good morning, doctor. I've been experiencing some very distressing symptoms lately.
I'm sorry to hear that. Could you describe the symptoms you're experiencing?
For the past few days, I've had severe abdominal cramps and diarrhea. It's very frequent and watery. I've also been feeling nauseous and vomited a couple of times.
That sounds quite uncomfortable. Have you noticed any blood in your stools, or has the diarrhea been very dark?
No blood, but it's been quite severe. I've also noticed a low-grade fever and some muscle aches.
Have you eaten anything unusual or been to any gatherings where food was served in the past week?
Yes, I attended a barbecue last weekend. I remember there were a lot of dishes, some of which were prepared by the guests.
It's possible that you could be dealing with a food-borne illness. Based on your symptoms, it could be an E. coli infection, which is commonly linked to undercooked meat or contaminated produce. Have you experienced any other symptoms, perhaps unrelated to your stomach?
Actually, yes. I've also had a rash that started a couple of days ago. It's quite painful and is located on my right side, wrapping around my torso.
A rash in that pattern can be indicative of shingles. It's a reactivation of the chickenpox virus that can happen particularly when your immune system is stressed, which might be the case if you're also dealing with an infection.
Could these two be related?
They might not be directly related, but both can flare up due to stress or a weakened immune system. Let's make sure we address both. I would recommend we start with some tests to confirm these conditions. For the gastrointestinal symptoms, a stool sample test will help us determine if it's indeed E. coli or another pathogen. For the rash, a clinical examination will usually suffice, as shingles has a very distinctive appearance.
What are the treatment options if these tests confirm your suspicions?
For an E. coli infection, treatment typically involves hydration and avoiding certain medications like antidiarrheals, which can worsen the condition. If the infection is severe, antibiotics might be necessary. As for the shingles, antiviral drugs are effective, especially if started early. They can help reduce the pain and the duration of the outbreak.
Is there anything I can do at home to relieve the symptoms?
Certainly. For the diarrhea, make sure to drink plenty of fluids. Oral rehydration solutions are ideal. Avoid dairy products and very greasy foods until your stomach settles. For the shingles, cool baths or compresses can help ease the pain. Over-the-counter pain relievers can also help, but I would recommend against using topical antibiotics or creams without consulting a doctor, as they can sometimes worsen the pain.
How long before I can expect some relief from these treatments?
If it's an E. coli infection, symptoms usually improve within a few days of proper hydration and rest. Shingles, however, can take a bit longer. The rash might begin to improve within a week, but the pain can linger. Sometimes people experience postherpetic neuralgia, which is a pain that persists after the rash has healed.
That sounds quite serious. Is there anything I can do to prevent complications?
The best approach is early treatment. For shingles, keeping the rash clean and dry helps prevent infection. Managing stress and ensuring you're well rested can also help your immune system fight off both the virus and any secondary infections. We'll monitor your symptoms closely and adjust treatment as needed.
Thank you, doctor. It's reassuring to have a clear plan. How soon should we schedule a follow-up?
Let's schedule a follow-up in 1 week to assess how you're responding to the treatment. If your symptoms worsen or you don't see improvement, I want you to come in sooner. Keep an eye on your temperature and hydration, and call the office if anything changes significantly.
Will do, doctor. Thank you so much for your help today.
You're welcome. Take care, and I hope you start feeling better soon.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning. Please have a seat. How can I assist you today?
Good morning, doctor. For the past few weeks, I've been feeling unusually tired, and I've been having some difficulty breathing, especially when I'm lying down. I also noticed my ankles are swollen.
I see. How long have you been experiencing these symptoms?
It started about a month ago, but has gotten worse in the past week.
Have you experienced any chest pain or palpitations?
Yes, I've had some chest pain, mostly mild, but it occasionally feels quite severe.
Do you have any known medical conditions, or do you take any medications?
I have hypertension, and I'm on lisinopril for that. No other conditions that I know of.
Does your family have a history of cardiovascular disease?
Yes, doctor. My father had heart disease, and my sister was diagnosed with some kind of valve problem.
All right. Based on your symptoms and family history, we might be looking at a case of congestive heart failure, but we need to conduct some tests to confirm this and to check if there's any other underlying condition, like issues with your heart valves.
That sounds serious, doctor. What kind of tests are we talking about?
We'll start with an echocardiogram to look at the heart structure and check for any abnormalities in the heart valves or chambers. We'll also do an ECG to monitor your heart's rhythm and a chest X-ray to see if there's fluid buildup in your lungs. Blood tests will be necessary as well to check for markers of heart disease and other related issues.
And what if these tests show that I do have heart failure or a problem with my valves?
If it's heart failure, the treatment will focus on managing the symptoms and preventing the condition from worsening. This includes medications like ACE inhibitors, which you're already on, diuretics to reduce fluid buildup, and possibly beta blockers. We might need to adjust your medications depending on the test results.
If we find any significant valve disease, such as mitral regurgitation or aortic valve issues, you might need medication to manage symptoms or even surgery to repair or replace the valve, depending on the severity.
What are the risks with these treatments, doctor?
The medications can have side effects, like kidney problems or changes in electrolyte levels, which we would monitor closely. Surgical interventions carry their risks, like any surgery, but the risk is often outweighed by the benefit if your condition is severe.
I understand. How soon can we start with these tests?
We can start with the blood tests and the echocardiogram today. The results will guide us on how to proceed. In the meantime, try to rest, limit your salt intake to reduce fluid buildup, and avoid strenuous activity.
Thank you, doctor. I'm a bit scared, but I'm glad we're figuring this out.
It's completely understandable to feel that way, but you're taking the right steps by addressing these issues early. I'll be here to guide you through every step of the treatment process. Let's focus on getting you feeling better.
Thank you, doctor. I appreciate your help.
You're welcome. We'll get through this together. I'll have my assistant schedule your follow-up appointment to discuss the test results as soon as they are ready. If you have any concerns in the meantime, don't hesitate to call the office.
I will. Thank you again, doctor.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Mr. Johnson was brought into the ER last night with complaints of chest pain and shortness of breath. He's a 55-year-old male with a history of type 2 diabetes and smoking. We've initiated oxygen therapy, and he's currently on a cardiac monitor. His initial EKG showed no signs of myocardial infarction, but we're keeping him for observation due to his risk factors. He's currently stable, blood sugar levels are slightly elevated, and we have started him on insulin as per sliding scale. His family has been notified, and they are on their way.
Now look at question 26.
I want to discuss our approach to handling chronic pain management in elderly patients today. It's crucial we address this sensitively, as our patient population is showing an increasing trend of non-compliance related to opioid therapies. Our review has shown that alternative methods, such as physical therapy, acupuncture, and mindfulness, are not being utilized as effectively as they could be. We need to ensure our staff is trained to offer these alternatives and to educate our patients about their benefits. This could potentially reduce our reliance on opioids and improve overall patient satisfaction with their pain management strategies.
Now look at question 27.
This morning we need to review our new protocol for handling potential stroke patients. Lisa, can you start us off?
Yes, certainly. We've got a new system in place for quickly identifying stroke symptoms using the FAST checklist: face drooping, arm weakness, speech difficulties, and time to call emergency services. Our goal is to decrease the time from patient arrival to treatment initiation. We're aiming for a door-to-needle time of less than 60 minutes for all eligible patients.
Excellent initiative. How are we preparing the staff for this change?
We've scheduled training sessions for all emergency and neurology department staff. Additionally, we'll run simulation drills twice a month to ensure everyone is clear on their roles and responsibilities.
Great. Let's make sure we also have feedback sessions post-drills to gather insights and improve where necessary.
Now look at question 28.
Dr. Reynolds, we're seeing an increase in flu cases this week. How should we proceed in terms of community outreach and prevention?
We need to start by increasing public awareness about the flu vaccine availability and the importance of getting it, especially for high-risk groups. Can we organize a flu shot drive at local community centers?
That sounds like a good plan. I'll coordinate with the Public Health Department to arrange for the vaccines and medical staff. Should we also consider extended clinic hours?
Yes. Let's extend our clinic hours during this flu season. We should also prepare educational materials that our staff can distribute during these hours to educate the public on not just vaccination, but also on basic preventive measures like hand washing and avoiding close contact with sick individuals.
I'll get on it right away and we'll report back with a detailed plan by tomorrow.
Now look at question 29.
How did the staff training on the new electronic health record system go today, Michael?
It was quite eventful. We encountered some resistance, as a few team members were overwhelmed by the new interface. I spent extra time walking them through the navigation and data entry processes, which helped them gain confidence.
It's important for everyone to feel comfortable with the system, especially since it affects all aspects of patient care. We should consider additional follow-up training sessions.
Agreed. I also think a quick reference guide might help ease the transition.
Good idea. Let's draft a reference guide and schedule another training session for next week.
Now look at question 30.
Dr. Lewis, There's been an increase in cases of hand, foot, and mouth disease among the pediatric patients this week.
Yes, I've noticed. It's crucial we advise parents on how to manage the symptoms and prevent the spread, especially since it's highly contagious.
Should we prepare a notice to send home with guidelines on hygiene practices?
Absolutely. Let's draft it together. We should include information on spotting symptoms early and when to seek further medical attention.
I'll gather the latest CDC guidelines to ensure our information is up to date. Shall we include tips on comfort measures for the children at home as well?
Yes, let's do that. Make sure to mention the importance of keeping children hydrated and the options for pain relief.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Welcome to today's discussion on the complexities of managing stage 5 chronic kidney disease with a focus on hemodialysis. Joining us is Dr. Emily Saunders, a nephrologist specializing in advanced CKD management and renal replacement therapies at the Harvard Medical School. Dr. Saunders, could you begin by explaining the significance of this stage of kidney disease?
Thank you for having me. Stage 5 CKD, also known as end-stage renal disease, ESRD, is the final stage of chronic kidney disease, where the kidneys have lost nearly all their ability to function effectively on their own. At this stage, patients typically have a glomerular filtration rate, GFR, of less than 15 millimoles per min, and the accumulation of waste products in the blood becomes life-threatening. This necessitates renal replacement therapies, such as hemodialysis or kidney transplantation, to manage symptoms and sustain life.
Given the gravity of stage 5 CKD, could you walk us through a case study that illustrates the challenges and management strategies for these patients?
Certainly. Let's discuss the case of a 62-year-old male patient with diabetes mellitus type 2 and hypertension who was diagnosed with CKD 5 years ago. Over the years, despite medical interventions, his renal function continued to deteriorate, and he transitioned to ESRD. He started on hemodialysis 3 times a week. His treatment illustrates several key challenges, including managing fluid overload, electrolyte imbalances, and cardiovascular stability during dialysis sessions.
That sounds incredibly challenging. How do healthcare providers tailor treatments for such complex cases?
In this patient's case, the hemodialysis regimen was specifically tailored to optimize fluid removal and manage his hypertension, which is critical to prevent complications such as congestive heart failure. Additionally, his dialysis sessions were closely monitored to adjust for electrolyte imbalances, particularly potassium and phosphate, which can be life-threatening if not managed correctly.
What are some advancements in hemodialysis that are helping patients with stage 5 CKD?
Recent advancements in hemodialysis focus on improving the quality of life and clinical outcomes. These include high-efficiency dialyzers that better mimic kidney function and wearable dialysis technologies that offer patients more mobility and independence. Additionally, there's ongoing research into hemodialysis timing and frequency to maximize toxin removal while minimizing the session's impact on the patient's daily life.
Considering the severity of stage 5 CKD, how do you approach patient education and involvement in their treatment plan?
Patient education is fundamental in managing stage 5 CKD. We ensure patients understand their condition, the importance of adhering to their dialysis schedule, and dietary restrictions. Moreover, we involve them in decision-making about their treatment options, like choosing between hemodialysis and peritoneal dialysis, or evaluating their eligibility for a kidney transplant. This inclusive approach helps in managing their expectations and improving their compliance with the treatment regimen.
Lastly, how do public health initiatives support patients with stage 5 CKD?
Public health initiatives play a crucial role in improving outcomes for CKD patients. These include screening programs to detect kidney disease early, educational campaigns to raise awareness about the risk factors such as diabetes and hypertension, and improving access to healthcare services. Furthermore, policies that support research funding for kidney diseases and subsidize the cost of long-term treatments like dialysis are vital in managing the disease on a larger scale.
Dr. Saunders, thank you for sharing your insights and the detailed case study on managing stage 5 chronic kidney disease. Your expertise provides valuable understanding into the complexities of this condition and the critical role of tailored treatment strategies.
Thank you for the opportunity to discuss this vital healthcare challenge. Educating the public and the medical community about CKD and its implications is essential in improving patient outcomes and advancing treatment methodologies.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Good afternoon, I am Dr. Emily Thompson, and today I'll be discussing an advanced topic in cardiology, specifically the management of heart failure with preserved ejection fraction, HFpEF, often referred to as diastolic heart failure. HFpEF is a complex clinical syndrome characterized by symptoms of heart failure, a preserved ejection fraction of more than 50%, and evidence of diastolic dysfunction. This condition is particularly challenging due to its diverse etiology and the lack of consensus on effective treatment strategies. HFpEF is increasingly prevalent, especially among the elderly and in patients with comorbid conditions such as hypertension, diabetes, and obesity. Unlike heart failure with reduced ejection fraction, HFpEF does not have well-defined treatment pathways, which makes patient management particularly challenging. It also has a significant impact on healthcare systems worldwide due to high hospitalization rates and associated morbidity. Let's delve into a case study that illustrates the typical complexities associated with diagnosing and managing HFpEF. We'll explore the case of Mr. John Carter, a 68-year-old retired teacher with a history of hypertension and type 2 diabetes. Mr. Carter presented to the clinic with complaints of increasing shortness of breath, fatigue, and swelling in his legs, worsening over the past few months. Initial assessment involved a detailed medical history and physical examination, which suggested heart failure. However, the echocardiogram showed a preserved ejection fraction of 55%, which is indicative of HFpEF. This was further complicated by signs of left ventricular hypertrophy and elevated filling pressures, suggesting diastolic dysfunction. Management of Mr. Carter's condition required a multifaceted approach. First, we focused on optimizing his blood pressure and diabetes control to minimize further cardiac damage. This involved adjusting his existing medication regimen and introducing a sodium glucose cotransporter 2 inhibitor, SGLT2 inhibitor, which recent studies suggest may benefit HFpEF patients by reducing hospitalization for heart failure. Next, we addressed lifestyle modifications. Mr. Carter was advised on dietary changes to reduce fluid retention and potentially alleviate symptoms. He was also enrolled in a supervised exercise program designed specifically for HFpEF patients. Exercise has been shown to improve quality of life and functional status in these patients, as it helps improve cardiovascular and muscular function. Over several months, Mr. Carter's condition showed improvement. His symptoms were better managed, and his hospital visits decreased significantly. However, managing HFpEF remains a long-term challenge, requiring ongoing adjustments to therapy and close monitoring. In reviewing Mr. Carter's case in our multidisciplinary team meetings, it became evident that HFpEF is not only a cardiac issue but a systemic one, necessitating a holistic approach to care. This includes regular follow-up in specialized heart failure clinics, involvement of dietitians, physical therapists, and cardiologists specializing in heart failure management. From this case study, several important points emerge. First, HFpEF requires a comprehensive diagnostic approach to differentiate it from other types of heart failure. Second, management strategies should be individualized, focusing on controlling comorbid conditions and symptom relief. Third, emerging therapies like SGLT2 inhibitors are promising, but need further investigation in this subgroup of heart failure patients. And final one, interdisciplinary care is crucial in managing complex cases like Mr. Carter's, highlighting the importance of integrated care teams in chronic disease management. HFpEF represents a significant and growing challenge in cardiology. Understanding its unique characteristics and developing tailored management strategies is critical for improving patient outcomes. Through research, clinical trials, and real-world case studies like that of Mr. Carter, we can continue to advance our knowledge and refine our approaches to this complex condition.